My name is Anjly Kunapuli, and I'm the Infectious Diseases Clinical Pharmacist at OSU Medical Center. Today, I will be presenting on Remdesivir pharmacotherapy for the treatment of SARS-CoV-2. This lecture is up to date as of May 5th and will be updated as new data becomes available. During this presentation, we'll go over the proposed mechanism of action of Remdesivir and the various ways to access it. We'll review the in vitro and animal data supporting its use against SARS-CoV-2 and discuss a recently published case series and clinical trial data of patients treated with Remdesivir. And we'll end with a summary of the current recommendations for its use. Let's start out with a little bit of background. Remdesivir is an adenosine nucleotide analog. It is a prodrug and is metabolized intracellularly to the active triphosphate form. Remdesivir works by binding to viral RNA polymerase and inhibits viral replication through premature termination of RNA transcription. Remdesivir demonstrates in vitro activity against several virus families. This is not a complete list, but includes Ebola and coronaviruses such as SARS, MERS, and SARS-CoV-2. As you may know, Remdesivir was under a compassionate use protocol during the Ebola outbreaks in West Africa. In 2018, the NIH initiated a study with Remdesivir and 3 other investigational agents for patients with Ebola disease. In an interim analysis of the data, the Remdesivir arm, along with the second treatment arm, were discontinued due to a higher survival rate than the other 2 treatment arms. Though favorable outcomes were not shown with Remdesivir against Ebola, this study provided important data regarding the safety and tolerability of the drug. Because Remdesivir has in vitro activity against SARS and MERS, along with some clinical data to support that, scientists targeted Remdesivir to investigate as a potential treatment for SARS-CoV-2. It is important to note that Remdesivir is an investigational drug and that there are no known drugs that have been proven to be safe and effective for treating COVID-19. Currently, there are 3 ways to access Remdesivir for use. The first is via enrollment in a clinical trial. There are 5 international multi-center clinical trials with Remdesivir for the treatment of COVID-19 underway. The first 2 trials listed aim to determine differences in clinical outcomes in patients who receive 5 versus 10 days of Remdesivir therapy with severe or moderate disease. These 2 trials are sponsored by Gilead and are known as the SIMPLE trials. Trials 3 through 5 are adaptive trials, which means that the study will compare different investigational agents to a control arm. Based on interim data analysis, new arms can be introduced or stopped based on the findings. If a therapy is proven efficacious, that therapy becomes a control arm for comparison to other investigational agents. Trial number 3, the Adaptive COVID-19 Treatment Trial, or the ACTT trial, is sponsored by the NIH. Interim data from trial number 1, which is the Simple Severe trial, and trial number 3, the ACTT trial, are recently released, which we'll discuss the details in a moment. But these data from these 2 trials led the FDA to issue an Emergency Use Authorization, or EUA, for Remdesivir. Trials number 6 and 7 were multi-center trials that included 10 hospitals from Wuhan, China. The studies were suspended and terminated respectively due to challenges in enrollment. The investigators of trial number 7 recently published their findings on the patients that they were able to enroll, and we'll discuss and review that data a little later in this presentation. The dose of Remdesivir that is being studied in these protocols is 200 milligrams IV on day 1, followed by 100 milligrams IV daily for 5 to 10 days, depending on the protocol. I have provided the clinicaltrials.gov identifiers for your various trials for your reference. The second way to access Remdesivir is via the Expanded Access Program. I have listed the inclusion criteria here for your reference. Expanded access should be considered for patients where enrollment in a clinical trial is not possible. For example, invasive mechanical ventilation was an exclusion criteria for many of the initial Remdesivir clinical trials. This program was a potential method for Remdesivir access for these patients. I have provided the clinicaltrials.gov identifier for the Expanded Access Protocol for your reference as well. The third way to access Remdesivir is via the Compassionate Use Program. Obtaining drug via this method is limited to children and pregnant women only, with SARS-CoV-2 confirmed by PCR. Additional information about this program and request forms can be found at the website listed here. On May 1st, the FDA granted Emergency Use Authorization, or EUA, for Remdesivir. Under the EUA, the FDA Commissioner can allow unapproved medical products or unapproved uses of approved medical products to be used in an emergency situation where there are no adequate, approved, and available alternatives. The scope of this authorization is limited to treat adults and children with suspected or laboratory-confirmed COVID-19 and severe disease defined as an SpO2 less than or equal to 94% on room air, requiring supplemental oxygen, mechanical ventilation, or ECMO. Directions on how to access Remdesivir through the EUA is not yet available. In the interim, a fact sheet for healthcare providers that outlines additional information about the drug and requirements for its use can be found at the FDA link provided here. Moving on to some in vitro data that is available for Remdesivir against SARS-CoV-2. This data was published in February of this year by Wing and colleagues, where they assessed the efficacy of 7 antiviral agents, including chloroquine, ribavirin, remdesivir, and favipiravir against clinical isolate of COVID-19. Efficacy and toxicity were measured using EC50 and CC50. Half maximal effective concentration, or EC50, is the drug concentration at which viral replication is inhibited by 50%. So ideally, we'd want this number to be low. CC50, or the cytotoxic concentration, is the concentration of the drug required to kill 50% of cells in uninfected culture. So ideally, we would want this number to be high. And sensitivity index, or SI, is the ratio between CC50 and EC50. And again, ideally, you would want a high number here because that would suggest a more safe and effective drug. This data supports that remdesivir and chloroquine are effective in vitro against SARS-CoV-2 infection and should be pursued for further investigation for COVID-19 treatment. In regards to preclinical data, the study was recently released assessing the clinical benefit of remdesivir in rhesus macaques infected with SARS-CoV-2. This is an unpublished study and has not undergone the peer review process. This study was a blinded placebo-controlled study comparing outcomes in animals that received remdesivir versus a vehicle solution. The primary endpoints were clinical status, viral load and titer data, chest radiograph data, and lung histopathology data. Treatment was initiated 12 hours after inoculation and continued daily for 6 days post-inoculation. The remdesivir group had a lower clinical and cumulative X-ray scores. These findings were statistically significant. In addition, a reduction in viral load in VL fluid and lung tissue were noted. The reduction in viral load in lung tissue was statistically significant. The first effects of treatment on clinical signs and virus replication were noted as early as 12 hours after remdesivir administration. 12 hours after treatment, the infectious virus titer in VAL was 100-fold lower in the remdesivir group compared to the control group and was undetectable by 3 days post-inoculation. No overall reduction in viral loads or titers in the nose, throat, or rectum were noted, which could have important implications for viral shedding and transmissibility. The authors concluded that there was a clear benefit of early remdesivir treatment in this animal model, and early remdesivir treatment in patients with COVID-19 may prevent progression to severe pneumonia. The next study, compassionate use of remdesivir for patients with severe COVID-19, was released in April of this year. This was the first data describing clinical outcomes in a cohort of patients with severe disease. Investigators evaluated outcomes in patients with severe COVID-19 who received compassionate use remdesivir from January 25th through March 7th, 2020. This reflects the time period when compassionate use was not restricted to children and pregnant women only. This was an open-label program and did not have a predetermined number of patients, sites, or duration. The inclusion criteria are provided and reflect criteria that were required for compassionate use eligibility during that time period and included patients who were hospitalized with SARS-CoV-2 confirmed by PCR, had an oxygen saturation of less than or equal to 94% on room air, or needed oxygen support. They had a creatinine clearance of greater than or equal to 30 milliliters per minute and an AST or ALT less than 5 times the upper limit of normal. Patients who used other investigational drugs were excluded. The planned treatment course was remdesivir 200 milligrams on day 1, then 100 milligrams daily for 9 days, standard supportive care. Duration of follow-up was at least 28 days after treatment or until discharge or death. There were no pre-specified endpoints for this program. The investigators quantified the incidence of key clinical events, including changes in oxygen support requirements, hospital discharge, and adverse events, including those leading to discontinuation of treatment, severe adverse events, and death. The investigators also evaluated the proportion of patients with clinical improvement, which was defined as a live discharge from the hospital, a decrease of at least 2 points from baseline on the modified ordinal scale, or both. The modified ordinal scale is a 6-point scale with categories ranging from not hospitalized to death. The categories in between reflect hospitalization with various oxygen requirements. 61 patients met inclusion criteria. However, 7 were excluded due to an absence of post-day 1 data, and 1 patient was excluded because of an erroneous remdesivir start date. 53 patients were included in this analysis. 40 or 75% of these patients received a 10-day course of remdesivir. Remdesivir was stopped in 13 patients before completing a 10-day course. 10 patients received 5 to 9 days of treatment, and 3 patients received less than 5 days of treatment. The shorter duration was attributed to hospital discharge prior to completion of therapy. Here are some baseline characteristics for these patients. For the 53 patients included in the study, the median age was 64 years, with 34% being greater than 70 years. 75% of the patients were males, and 68% had coexisting conditions including hypertension, diabetes, hyperlipidemia, and asthma. 34 patients required invasive ventilation, with 30 requiring invasive mechanical ventilation and 4 requiring ECMO. 19 patients required non-invasive oxygen support, which includes non-invasive positive pressure ventilation, high flow oxygen, low flow oxygen, and ambient air. The invasive ventilation group included a larger percentage of males with a median age of 67 years and with a higher incidence of comorbidities at 74% compared to the non-invasive oxygen group. The median duration of symptoms before initiation of remdesivir was 12 days. After a median follow-up of 18 days after receiving remdesivir, 36 of the 53 patients, or 68%, showed an improvement in oxygen support from baseline. This is represented by the area in light blue. 17 of 30 patients requiring invasive mechanical ventilation were extubated, and ECMO was stopped in 3 of the 4 patients who required it at baseline. 25 of the 53 patients, or 47%, were discharged, 24% of whom received invasive ventilation, and 89% who received non-invasive oxygen support at baseline. 8 of the 53 patients, or 15%, showed clinical worsening. This is represented by the area in dark gray. By day 28, the cumulative incidence of clinical improvement was 84% by Kaplan-Meier analysis. Looking at clinical improvement based on baseline oxygen support requirement and age, clinical improvement was less frequent among patients receiving invasive ventilation than among those receiving non-invasive ventilation, and among patients 70 years of age or older compared to those less than 50 years of age. Looking at the mortality data, 13% of patients died after remdesivir treatment, 6 in the invasive ventilation group, and 1 in the non-invasive oxygen support group. The median interval between remdesivir initiation and death was 15 days. An increased risk of death was reported in patients who were greater than or equal to 70 years of age compared to those that were less than 70 years of age, with a hazard ratio of 11.34. Those that had a higher serum creatinine at baseline, which was associated with a hazard ratio per milligram per deciliter of 1.91, and those that received invasive ventilation compared to those requiring non-invasive oxygen support with a hazard ratio of 2.78 for mortality. The increased risk of death in patients requiring invasive ventilation was not statistically significant, as the confidence interval here included 1. Adverse events were reported in 60% of patients and were common in patients requiring invasive ventilation. The most commonly reported adverse events were elevated hepatic enzymes and diarrhea, along with renal impairment, hypotension, and rash. Of note, remdesivir contains a vehicle called beta-cyclodextrin, that can lead to worsening renal function in some patients. 23% of patients experienced serious adverse events, and 8% or 4 patients required discontinuation of therapy. 1 patient due to multi-organ failure, 2 patients due to elevated hepatic enzymes, and 1 patient due to maculopapular rash. So to summarize the findings of this study, clinical improvement was observed in 68% of patients with severe COVID-19 who were treated with compassionate use remdesivir. It is difficult to determine the true efficacy of remdesivir from the study, as there was no control arm for comparison. And lastly, results of ongoing randomized placebo-controlled trials will hopefully provide stronger evidence regarding remdesivir use in patients with COVID-19. Some limitations of the study include the small cohort size of 53 patients and that there was no control group for comparison. In addition, there was no other information provided about the 8 patients who were excluded from this analysis. Other limitations include the short duration of follow-up in the study, which is a median of 18 days. Further, remdesivir was administered late in the course of disease. The median duration of symptoms before initiation of therapy was 12 days. It is hypothesized that a greater benefit may be observed if therapy is initiated earlier, considering the mechanism of action of remdesivir in inhibiting viral replication. Another limitation is that the duration of remdesivir therapy was not uniform in the study, as clinical improvement enabled hospital discharge. And lastly, there was no viral load or virologic outcome data provided. Let's move on to the interim data from 2 currently ongoing trials that resulted in the FDA issuing an emergency use authorization for remdesivir. The first one I'll discuss is the adaptive COVID-19 treatment trial sponsored by the NIH. This is a multi-center adaptive randomized double-blind placebo-controlled trial to evaluate the safety and efficacy of different investigational therapeutic agents in hospitalized adults with COVID-19. In this trial, interim monitoring was conducted by an independent data and safety monitoring board to make recommendations about changes to the study arms if necessary. Adult patients with SARS-CoV-2 infection confirmed by PCR with one of the following: radiographic infiltrates by imaging, oxygen saturation less than or equal to 94% on room air, those requiring supplemental oxygen or requiring mechanical ventilation were included in this study. Patients with ALT or AST greater than 5 times the upper limit of normal, an estimated GFR of less than 30 milliliters per minute, and pregnant women were excluded. The initial treatment arms evaluated were remdesivir 200 milligrams IV on day 1, followed by 100 milligrams IV once daily for up to 10 days versus placebo. The primary outcome was time to recovery by day 29. Day of recovery was defined as the first day in which the patient meets one of the following 3 categories from an 8-point ordinal scale: hospitalized, not requiring supplemental oxygen or no longer requires ongoing medical care; not hospitalized, limitation activities and or requiring home oxygen; and lastly, not hospitalized, no limitations on activities. Preliminary results based on data and safety monitoring board assessment showed that patients in the remdesivir group had a 31% faster time to recovery compared to those in the placebo group. This finding was statistically significant. The median time to recovery was 11 days and 15 days for patients treated with remdesivir and placebo, respectively. A survival benefit was noted with a mortality rate of 8% for the remdesivir group versus 11.6% for the placebo group. More comprehensive data, including additional information about the trial results, should be available in the near future. The NIH will also provide an update on plans for incorporation of additional investigative treatments into the study. The second trial is a study to evaluate the safety and antiviral activity of remdesivir in participants with severe coronavirus disease, or the Simple Severe trial, which is sponsored by Gilead. The study originally planned to enroll 400 patients and was amended to enroll another 5,600 patients in an expansion phase and will include patients on mechanical ventilation. So this is the interim data for the first 400 patients, but it will give perspective into what led the issuance of an EUA for Remdesivir. The objective of this trial was to determine whether there was a difference in efficacy and safety in patients with severe disease receiving a 5-day versus a 10-day course of Remdesivir. Children greater than the age of 12 years and adults with SARS-CoV-2 confirmed by PCR and oxygen saturation of less than or equal to 94% on room air or requiring supplemental oxygen at screening were included. Patients were mechanically ventilated, had a creatinine clearance of less than 50 milliliters per minute, and an AST or an ALT greater than 5 times upper limit of normal were excluded. The two treatment groups were patients receiving Remdesivir for a 5-day versus a 10-day duration of therapy, in addition to standard of care. The primary outcome was clinical improvement on a 7-point ordinal scale on day 14. The secondary outcome was the proportion of patients with treatment-related adverse events. Looking at the results that I've put here directly from the press release, similar improvement in clinical status was achieved in patients receiving a 5-day or a 10-day course of Remdesivir by day 14. Time to clinical improvement for 50% of the patients was 10 days in the 5-day group and 11 days in the 10-day group. More than half of the patients in both groups were discharged by hospital day 14. After pooling data across treatment arms, 62% of the patients who received Remdesivir within the first 10 days of symptom onset were able to be discharged from the hospital by day 14, compared to 49% of patients who were treated after 10 or more days of symptoms. The most common adverse events observed in both groups were nausea and acute respiratory failure. 7.3% of patients had grade 3 or higher liver enzyme elevations, with 3% requiring Remdesivir discontinuation. In general, there were no new safety concerns noted. A peer-reviewed publication of this data will be forthcoming in the next few weeks. The last trial that I wanted to briefly touch on is Remdesivir in adults with severe COVID-19, a randomized double-blind placebo-controlled multi-center trial which was initiated in Wuhan, China. In this trial, use of treatments including lopinavir, ritonavir, and interferon alpha-2b in addition to the investigational treatment was permitted. The primary endpoint was time to clinical improvement within 28 days after randomization. About 453 patients should have been recruited for this trial. However, due to the control of the outbreak in Wuhan, only 236 patients were recruited, and as a result, the statistical power was dropped to 58%. Based on termination criteria, the study was halted and the available data was analyzed. So here are the results. In the intent to treat and per protocol population, the time to clinical improvement in the Remdesivir group was not significantly different compared to the control group. In the intent to treat population, patients that received Remdesivir within 10 days of symptom onset had a faster time to clinical improvement at a median of 18 days compared to 23 days in those who received placebo. This finding, however, was not statistically significant. In addition, 28-day mortality was not significantly different between the two groups. Adverse events were reported in 66% of patients treated with Remdesivir compared to 64% that received placebo. Treatment was stopped early in 12% of patients treated with Remdesivir compared to 5% of patients in the placebo group. The investigators concluded that larger ongoing trials will continue to improve our understanding of Remdesivir for the treatment of COVID-19. They suggested that strategies aimed at improving the potency of Remdesivir, such as using higher doses or perhaps in combination with other potentially therapeutic agents, and strategies for mitigating immunopathological host responses should be investigated. Given all of the recent data surrounding the use of Remdesivir in patients with COVID-19, it is important to understand that recommendations for its use continue to evolve. Based on the data that I have shared with you today, and though it may seem promising, there is insufficient data to recommend Remdesivir as first-line therapy for the treatment of COVID-19. If eligible, enrollment in clinical trials should be considered. Remdesivir is available via an expanded access program and a compassionate use program for patients who meet criteria. Though an emergency use authorization has been issued for remdesivir use, details regarding the availability and distribution of the agent have not been disclosed. As additional information becomes available, I will update this presentation accordingly. Thank you.